Good afternoon, everyone. Hey, it's great to see you. Thank you for your patience. We were just letting a few more people join real quick, but it's great to have you here with us today. My name is Chad Erickson. I'm the Vice President of Strategy at MyAdvice, and good to have my friend, Dr. Jeff Farah, here with us again. Jeff and I had an opportunity to do a webinar. Gosh, Jeff, it was about 6 or 8 weeks ago, and it was great. But looking forward to having you visit with the MyAdvice audience today. For everyone who's attending, just a couple little things and kind of housekeeping things, if you will. So I'm going to moderate the panel today, and we're going to hold off the questions until the end. You can ask your questions at any time, of course, and I'll respond to you, but I will moderate those and hold them until the end. You can do that either through the question section or chat, either way, and I'll see both of those. This is also being recorded, so if you want to go back and watch it later, you have somebody else in your practice that you want to have see this, it's going to be available. So anyway, all that's great. But let me introduce Dr. Farah today. I want to turn the time over to him and give him as much time as possible. So Dr. Jeff Farah has a very long and diverse medical background. Dr. Farah is a practicing chiropractic physician, as well as a nurse practitioner licensed in Florida and South Carolina. In addition, Dr. Farah is licensed in acupuncture and graduated from massage therapy school and has a degree in nutrition and fitness. Dr. Farah runs a private practice in Tallahassee, Florida that combines a full-service gym, IV lounge, and rehab center as part of his concierge medical practice. And Jeff, if I lived closer, I'd come see you. I blew up my ACL and MCL last week. I'd come let you put me back together. Anyway, but Dr. Farah oversees all the in-person virtual practitioner trainings for Pellecome, and that's why he's here today. He brings a wealth of knowledge when it comes to bioidentical hormone replacement therapy, and more importantly, the finer points of using the RE3 advanced pellet delivery system. So you're really going to find out today why this is superior, how this really can help your practice grow. And I want to just add quickly that the reason that we put this out to our audience is that we often hear from our, all of our practices, Chad, medicine is changing. We need to find another way of delivering something quality to our patients that's going to not only help our revenues, but deliver something that's valuable to them. And that's where this really comes in. So as you listen today, take copious notes, listen intently, because I believe you're going to hear something that's really going to resonate with you. Of a great way to add an additional revenue stream to your practice. But Jeff, I'm going to go ahead and mute myself and turn off my camera and let you take it away.
All right. Hey, everybody. Thanks for having me here, and I appreciate that, Chad. Yeah, so let's talk. I'm running in from a patient, actually, so just leaving a hormone patient. And so we'll talk on some of the details of hormones, but I also want to talk on some of the details of, like he said, the changing of medicine. So I run a concierge practice, which means I run a smaller membership-based practice. I use the word concierge or direct primary care. I don't know which one you would classify me technically as, but I don't see walk-ins off the street. I don't do, call, make an appointment. We don't know who you are. I do referral only, and I don't bill insurance. So this thought in the medicine world that patients aren't willing to pay cash for good service, for a different style of patient-doctor interaction is not true. I have built my entire practice on that. I don't bill insurance under any sort at all. I don't participate in any networks or anything like that. So all of my practice is cash-based practice. So this presentation is going to be presented by Pellecome. I do their in-person and online device training for their hormone delivery system, their RE3, and it is quite literally saved my practice. Is how I got involved with Pellecome. If you have done hormone replacement, specifically if you have done pellet implants with the old Trocar device, either sold through a pharmacy that maybe sells you the pellets or another management firm, then you know that it can be borderline barbaric, the insertion, especially for males. I was one of those males. I had it once, so I was a nurse working in a hormone replacement clinic, and I had the procedure myself, and I thought, this is the worst thing I've ever experienced in my life. I couldn't go back to the gym for 10 or 12 days. I bruised. It was so painful. I could barely sleep that night, and I was like, this is just awful. But yet I felt so much better that I was in this like rock and a hard place. I was like, there has to be something better. I hated shots. They just were not well for me. But this pellet implant initially was just terrible. And then I just happened to stumble upon Pellecome and took their training class, and I was like, holy moly, this is night and day. I was like, no stitches? The doc's like, no, we're not doing stitches. And I was, all these things that we were having to do after procedures was significant. And so today we're going to go through some of those procedures, and then we'll talk about some of the pros and cons of this. So today we want to talk about specifically, this is not geared towards being an education only in terms of hormones. So we're not going to tell you specifically like, here are the intricacies of estrogen, progesterone, testosterone, but I want to start teaching you and the people in your office how to start screening for these. I quite literally started, my first patients came from my chiropractic side of my business, and the doctor who took over that chiropractic side of that, and just talking to patients and educating them. So we're going to learn about progesterone, estrogen, testosterone for women. We're going to learn a little bit about testosterone and men's health, and then we're going to learn about some of the specifics of pellet therapy, and then we're going to talk about Pellecome specifically. And then I have a video on here that we're going to show you in terms of an actual procedure happening and what it looks like and the device, so you guys can see actually what we're talking about live, or I should say recorded on a patient actually getting an insertion. So again, that's my other things that we're going to be talking about. Let's get right to it. So when we talk about hormones, I don't want to bog down to the science, but we know that the word hormones just doesn't mean sex hormones, right? So there are other ones, right? I think a lot of times in medicine and even in patients, they say hormones, they mean, they just mean testosterone, progesterone, estrogen, or they mean just estrogen. Like a lot of women have never heard the talk of testosterone talked about in their world of hormones, but it's a significant hormone for women. There's even some arguments that testosterone is the predominant female hormone throughout the life. If you take pregnancy out of the picture, there is some legitimate cases to saying that testosterone is the dominant hormone for females. But we know that the cortisol, insulin, thyroid, these are factors, but we're going to be talking about specifically the majority of today, we talk about the sex hormones. So what causes hormone imbalances, right? The age-old million-dollar question. I had a patient just ask me today, and the short answer I tell them is, we're not sure. There are some known things, right? There are some pharmaceutical. I have a patient, believe it or not, they go through opioid and then methadone clinics, and that's going to tank your testosterone. Prednisone actually is one of the worst things. Long-term prednisone use is classically implicated in testosterone dropping. I don't think a lot of doctors know that or tell their patients that. But there are the classics that we say, but I don't know that we give much credence to. But your patients 100% feel these things. It's the age, it's the stress, it's lack of sleep. Lack of sleep is a big one. Lack of exercise. Exercise is a hormone balancing act. If we don't do that, then it leads to these other things, eating problems. And then the big one that is starting to get more and more news, and that I think we'll find out in the next decade or two how much it's really played, are environmental toxins. Plastics and endocrine disruptors are a significant problem for hormone imbalance. But the short answer is, it's a lot of times not something that you'll be able to give your patients a clear-cut answer, like this is when it happened and this is why it happened. It's likely a culmination of all of those things. You will likely see trends of this: stress, lack of sleep, high anxiety and stress that just wrecks our imbalances and our hormone balances. So when we're talking about these symptoms and screening patients and finding those patients in your practice, you don't necessarily need to dig deep when you start looking at the symptoms of this, right? So we have fatigue, we have weight gain, we have brain fog. That probably describes a majority of patients that walk in your door if you're doing primary care. I mean, I don't know a single patient that I saw when I worked primary care that didn't have fatigue and weight gain, right? So I just started checking patients more thoroughly and doing a hormone profile instead of just doing my thyroid. Okay, you're putting on some weight, you feel like this is slowing down, let's check your thyroid, right? That's the common thing. I was like, well, let's check your estrogen, progesterone, and testosterone as well. When you start talking about brain fog, this is a significant issue as we hit, you know, in our 40s and into our 50s, and patients want to be able to function for a quality of life as well. Low libido is a big one. I think if you would start talking to your female patients as well as your male, but especially your female patients, I don't know that I was ever taught to ask them that question, and it just seems different to them initially, but they're like, yeah, that is important to me. It's not just a male dominated thing. Like libido is important for females, and they want to be as close to their partners. Just it's not just a physical act, right? So it's important for emotional connecting to your spouse. So low libido is important. Blood sugar dysregulation, this is a big one. There is an intimate link between rising A1Cs and hormones, specifically your testosterone imbalances. So I did my grand rounds presentation in nurse practitioner school on this. There's a wealth of information on the type 2 diabetes profile and insulin, specifically insulin sensitivity and testosterone levels. Now, I wouldn't say it's hashed out whether it's the chicken or the egg, right? Does the diabetes come first or does the testosterone come first? But we typically will find those two together, right? Their A1C going up, their testosterone coming down. In my opinion, you would be doing a disservice to any of your type 2 diabetes patients, your insulin dysregulation patients, if you are not checking their testosterone. It is a significant issue with these patients, as well as a significant help when you correct it, right? And so the increase in metabolic tissue, the increase in testosterone, the increase in ability to exercise significantly helps regulate their insulin blood sugar. In addition to that, we have the classics, right? We have hot flashes. I think every doctor, patient probably knows that's related to estrogen, but you have mood swings, lack of sleep, increased fat deposition, vaginal dryness. And it's important too, when you talk about libido with your female patients, that you expand a little bit more on that. Like you need to talk about, is it painful when we're having intercourse, or is it just that you don't want to, or do you not want to because there's low lubrication or there's vaginal atrophy? But these are important distinctions to make because those are different sides of the spectrum in terms of your hormone profile. So let's specifically touch briefly on estrogen. So the physiological role of estrogen, I think estrogen is always considered the significant female hormone, right? We have sexual development, we have menstruation. These are obviously integral parts of females. And so not only does it affect that, but there are more interplays throughout. We have some mood control, we have some metabolism control, bone density, significant cause of postmenopausal bone loss is loss of estrogen, significant. We also have this mood. I think one of the things I notice most commonly from a pre-perimenopausal woman, the first thing that they're given is Prozac when they're primary care, which it really struck me was these women started to come in with these mood stabilizers or antidepressants, and in reality, we dig a little deeper and there may have been some hormonal imbalance definitely contributing, if not the major factor in that. So as that estrogen drops, right, you're going to see these things be affected. So you're going to see bone loss significantly affected in a postmenopausal woman. You're going to see cardiovascular protection that is maintained through maintaining your estrogen. There's even some, the risk of cancer, but there's also some cancer protective mechanisms to estrogen that we need to be aware of. And so you need to look at things like ovarian cancer. And so estrogen is fairly complex. But not only does it control hot flashes and incontinence, but things like anxiety are important. Skin changes are important. I was training a clinic up in Fifth Avenue, New York, big, beautiful, multi-million-dollar clinic, right? And they had a program that they called metabolic aesthetics. So not only did you do aesthetics from lasers and Botox and fillers and things like that, but you went on a metabolic program to heal from the inside out. And some of their results I got to see firsthand were quite amazing through IV and hormone use to complement. You know, their theory was, if you're going to spend thousands of dollars on a facelift or some other procedure that costs a good amount of money, would you not do well to also heal and speed up that repair and prolong the benefits of this procedure from healing you from the inside out, doing various peptides and hormones? And the results were quite amazing. When we look at progesterone, I think most of the talk about progesterone revolves around maintenance and pregnancy and things like that, but it is also a predominant pre, peri, postmenopausal hormone that needs to be discussed. It's a hormone 101, right? It is protective of the endometrium. So if you are going to give a woman estrogen and they have a uterus, you must give them progesterone. I just got out of a consult and the lady was postmenopausal, went on hormones, started having a cycle, and I was like, well, let me see your labs, what your progesterone level's at. Doc never gave her progesterone. It just seems like that's 101. You must do that. But it's more than just endometrium protection, right? It's more than this clinical data point that we have put out there. It also affects your sex drive. It also affects your anxiety depression scale, and it has a sedative effect, so it helps improve sleep, but it also sort of balances out that high estrogen that a lot of women are experiencing, this sort of estrogen dominance, so to speak. It can also help with milding out some of the subjective complaints from hormone replacement. It helps with irregular bleeding, whether or not you're on hormones or not. And it also influences weight gain. There's also some brain health that comes along with it. So it's important to understand that progesterone is not just this hormone of pregnancy. Testosterone. And so I think this one is a little bit different for a lot of docs in the terms of like testosterone in women. Like, a lot of your patients won't be prepared for that talk either. But just as it's important for your males, it's as important for your females, maybe just in smaller relative doses, but no less significant, right? So it still controls muscle mass. Muscle is still important for females. I work, like I said, my practice is a concierge practice, but I have a full service gym as a concierge gym, more like a CrossFit model, boutique model gym that's attached to it. But I tell you, women care about muscle mass. Women care about exercise. Women care about being fit. It's not just a man-dominated industry. It controls your fat distribution, so where you start to lay your deposits of fat, bone density, fertility, red blood cells, energy, mood, libido. These are important things that come from through the control of testosterone. So yes, women, you make testosterone. I think that goes without saying, but maybe it should be said a little bit more. So your adrenals and your ovaries pick up that role while you're pre-menopausal states. Post-menopausal, those ovaries start to really decline, and the adrenals pick up the brunt of that. And then you also get this conversion that happens in peripheral tissue. So it's multidimensional in females, and the multidimensional nature of the testosterone lends itself to, and we'll talk about this later, but a disconnect when you're talking about testosterone replacement and serum levels post-treatment. It's because of this multifactorial distribution of testosterone for a female. So again, the symptoms: brain fog, low sex drive, depression, fatigue. And I would furthermore say that depression especially is a bit more nuanced. It's not true clinical overt depression, but more like my daughter would call the ho-hums. Like, you just lose a little bit of your care. You get apathetic to the things that you really enjoyed. I used to love to play tennis, and now it's like an act of God to get me out of the tennis course. And I used to be super competitive, right? You lose a little bit of that oomph, that drive, that volition. And it's important. It's important for men and women. And yes, women can get testosterone replacement. Women do quite well on testosterone replacement, especially from pellets. And it is an important treatment modality to have in your back pocket. But again, the use of testosterone for women, you have to be comfortable with these. Women are going to ask you, is this FDA approved? They've been around since the 30s and 40s, is quite widely used, but you need to understand the legality. You need to understand the comfortability and answer those questions honestly in your patients. So they are technically off-label use. Whether it be for decreased libido, whether it be for mood changes, weight gain, energy, quite effective, but you need to understand when you're talking to patients the reality of the situation. So initial recommendations that they used to be for women was, use the lowest dose, use it for 5 years, stop afterwards, right? After you get to that, and stop at 65, no matter what. And a lot of this was due to the fact that we were talking almost exclusively about estrogen, unopposed estrogen, because it doesn't matter why, but that's what we were talking about. Like we weren't significantly including a full hormone profile when we talked about these recommendations for women. So as time has gone on, and the industry in terms of research is growing, and the panel of hormones being offered, including progesterone, including testosterone, has changed, you're starting to see some new guidelines that come out. It is best and the most beneficial for women under 60 years old. It's best to initiate it earlier rather than later. And best within 10 years of the onset of menopause, right? So if you want to reduce, this is sort of risk management side of this as well. If you want to reduce the risk management of bioidentical hormone replacement, it's better to start it within that 10-year window, and it's better to start it sooner rather than later. But also, there's no reason to discontinue hormone treatment for women over 65, right? Better cognitive states are conferred from lifetime estrogen duration, right? So the longer, the more exposure to that estrogen that a woman has gives us better cognitive protection, right? And there's also some cardiovascular protection. Also, it just maintains a better, healthier quality of life. I don't think that health optimization is any less of a lofty goal than disease treatment. Prevention is where my clinic lives. Optimization is where my clinic lives. We 100% push towards that. I think it's important, and so do our patients. So the optimal candidates that would be in your practice, like who are these people that if you're like, I've been thinking about this, but I don't think I have those candidates, you 100% have the candidates, right? Until you start asking it, you would be surprised. But it starts in your mid, I would even say skewing to early 40s at this point. We're living such on-the-go lives that I think it's becoming more and more prominent in younger and younger populations. So I would say the younger 40s, early 40s are important as well. But especially as we start to get to those mid to later 40s, significant issues, mood swings, irregular bleeding, brain fog, insomnia, low libido. These are all things that significantly impact a woman until she's menopausal, right? But leading up to that state, your women are not being talked to until they have the hot flash. There's no talk of it being hormone related, just not on their radar. But you'll run a lab on a female and her testosterone will be 3, right? It's just virtually non-existent. She might only be 42, right? Well, of course her libido is going to be low. Of course her mood is going to be slightly depressed. Of course she's going to have excess fat deposition. And these are important. And then you start talking about brain fog and being successful employer, employee, a father, a mother. Like these are the reasons why we do hormones, specifically testosterone in that case. I think testosterone has a bit of still a history of thinking it's for something other than it is. I tell my people who come to my clinic, the patients in my clinic are not trying to be bodybuilders. It's not what we do, right? We're just trying to be better husbands. We're trying to be better fathers and mothers and wives, and so we can play with our kids and we can have optimal preventative lifestyle. Like that's what we're looking for, and that's what your patients are wanting. I think one of the things that came out of COVID is you never saw such a host of people pay this close attention to details, right? Everyone started reading research, and it was a bit of a cluster for sure when the general population is trying to bring up absolute versus relative risks, and they're trying to look at research studies, and they're trying to understand these nuanced things. But all in all, that's a good thing, right? They're starting to realize that, hey, maybe I can take a little more control of my own health. Maybe I can do that, right? What if we poured all that attention that we spent hours and hours and hours watching CNN and looking at journals and wondering, what is vitamin D related to? Maybe I should look at my vitamin D. Maybe I should ask my doctor, right? What if we did that into health optimization? Why not pour all that same energy into health optimization? And so I think your patients are getting more and more in tune to that. So here's a good little graph of your patients, and you're going to start to see in that 35 to 45 range window, you're going to start to see younger and younger women, if you talk to them, where their cycles become less than optimal, their hormone levels start to drop, and then that perimenopausal state can last 5, 7, 8, 9 years, right? That's a long time to live with a symptom when that could be easily fixed. Let's talk about hormone recommendations in men. And so this one, I run both male and female, but I think probably 60-40 leans towards males. And so I'm seeing younger and younger and younger males with clinically deficient, not suboptimal, but clinically deficient testosterone. 28-year-olds with a testosterone of 220, 27-year-olds. It's not uncommon. Of course, I have selection bias. I know that. You don't come to me and I'm feeling great. Can you check my testosterone and my thyroid? Right? It doesn't happen, but still, I would have never thought there would be that many 20-something-year-old men with testosterones in the 2s. It's unbelievable. And so it's becoming more and more of a major medical concern, and it's not so stigmatized. Even this picture, like, I don't even think this picture it really recommends or really relates to the significant population that I see in my practice of men. It's not people wanting to look like this. It's people who are just like struggling at 29. They're sleeping 8, 9, 10 hours a night. They feel like they're dragging. They're a 29-year-old with no libido. And they're like, I don't know, my fiance thinks I'm cheating on her. I hear that story a lot. Like, I just don't care anymore. Like, I'm 28, something's not right, And so on the other end of the spectrum, there's no real clinical basis to say, oh, you're too old for testosterone therapy, right? There's nothing wrong with a 60-plus-year-old man taking testosterone. It's effective, widely effective. It has rational, evidence-based clinical decision-making behind it. There's plenty of evidence for it. There's no real significant evidence of cardiovascular risk. I just had a patient, got his testosterone, younger guy, 192, he's 35. He's like, I gotta talk to my internist. Internist tells him, oh yeah, you're fine. You don't need testosterone. What's your values? He's like, oh, well, those are really low. Yeah, you should get that checked. Like, well, how did that change in a dime? So he's like, well, my neighbor's a cardiologist. I want to talk to him. I see him too. So he talks to the cardiologist. No real significant cardiovascular issues. So he comes back in today. He's like, okay, now I'm ready. Right. So I applaud him for doing his due diligence. We shouldn't just take one person's opinion, but there is no strong evidence, if any, that cardiovascular, when done appropriately, it does not increase the risk of any cardiovascular events. Anything done inappropriately, anything can increase cardiovascular. Potentially, you could exercise too much. It can cause cardiovascular issues, right? Extremes of lots of things cause negatives, but when done to physiological values, treatment stays in physiological values. Right? We're not going to 2,500. We're not shooting someone's testosterone up to 3,000. We're not taking mega doses of this. This is ethically based on normative data for males, right? We're staying in that 8 to 1,200 range for testosterone replacement. And you'll find most men don't really even need anywhere near to those values, right? You treat to the symptom abolishment and then you're done. If 700 is it, then 700 is it. If 800 is it, if 600 is it, you don't need to go above and beyond. And again, there's still this antiquated misnomer that prostate cancer risk is increased from testosterone. There's really no evidence to support that. Some of the new research is actually showing a drop in testosterone combined with a rise in estrogen may be producing the right environment for prostate cancer. So that would be interesting to see how that plays out over the next decade. Again, here's a nice little graph that shows testosterone values for males. And And so you're going to start to see declines that happen primarily in this 40s range. But here, this 40, like if you ran this over a male 40 with 600 testosterone, yeah, I tell them, and you're 700, don't waste your time. Like, it's not worth your bang for your buck. Now, you might have been an outlier and it's potentially is really low for you, but it's probably not true. But you'll commonly see a 30-year-old come in here and they'll come in at 300. There's no way you can tell me that a 300 testosterone in a 29, 32-year-old male is normal, right? You get the estrogen, or you get the testosterone of a 60, 70, 80-year-old, right? They're going to start to see these things. Loss of sex drive is one of the first clinical indicators that comes up from testosterone dropping. There's not much else for males other than psychological issues in terms of like they just don't like their partner, significant stresses, things like that. But after 30, you should start to see a normal natural decline about 1% a year. It should not be dropping at 10, 15, 25% a year. So this is a graph that shows you pellet implantation versus other modes of, where did my mouse go? There it is. So the pellets, the good thing about pellets is this nice consistent level of hormones. Injections give you these, I would say it's even a little bit more upside down V shaped than that. It's a real big spike followed by a real big drop off. Patches, orals, and creams are hard to even just get them high enough. They can give you some of this consistency with patches, but it's really hard to get to physiological levels that are necessary for symptom resolve. So what are pellets? They are literally just testosterone, bioidentical hormones that are compressed into small little cylinders. If you think of a Tic Tac, that's a good example. I don't have one on my desk. I should have grabbed one, but we'll see one here in a second. The size of it differs based on how many milligrams of hormone that you're putting in the patient. Estrogen tend to be really small. Male testosterones are the biggest of them, but you sort of customize the dose based on each patient. You can do other pellets other meds in pellet form, and actually they're starting to use naltrexone for weight loss in a pellet formation, which is kind of cool. Pellecome started to do that as well. So that's something to consider for weight loss for clinically obese patients. You don't have to worry about compliance. It's a great way to bypass enteral hepatic circulation. Doesn't significantly affect the clotting factors like the other ways do. You have great compliance, right? They come in office and they're effective. There's no wondering, will the testosterone rise? It will 100% rise, right? They will absorb their estrogen, not like creams and patches. If you ever worked with creams for males and testosterone, it's not uncommon to see that testosterone actually drop, right? It gets enough just to get that negative feedback loop, but not enough to push the levels higher. So the man's testosterone actually drops, which is so counterintuitive. Then they wonder why hormones didn't work for them, right? So pellets are a great option. Plus, like, there's no better way to have a good relationship with patients for them to come in for a quarterly or every 4-month visit and to be actually happy to see you because they're getting a service that they want to see, as opposed to this dreaded exam or this yearly, or I got to go see my doctor, or whatever it is. Like, they're happy to see you, you're happy to see them. It's a win-win revenue driver for your practice, as well as a treatment that they love and want to, and are willing to pay for. Like, it just changes your whole paradigm of your practice. I don't mind going to work today. There is no drudgery of coming to practice because I got a list of 10 to 15 patients who want to see me that day. They're happy about it, and I'll sit and talk for 15 minutes with them, and we can talk about pros and cons and optimization and all those things. Like, it's a great way to practice. I don't see any other way to do it. During my preceptorship doing primary care, I just was like, oh my God, this managed care is horrendous. Like, the managed care here in Tallahassee mandated that we had 10-minute blocks on our schedule available for patients. The 10-minute blocks, they come in, you got to do that standard thing. You got one question today, ma'am. Like, what is this? Like, we're not getting anywhere. And I got 10 minutes to solve it. Nothing's getting solved. It was a terrible way to practice, right? So for me, the pellet implants significantly changed the way I practice, significantly changed my view of how medicine can be run. And it was great for me. This is not supremely important, but there's a good picture down there in the bottom right of what the pellets look like, little cylinders. They are compressed testosterone made from yams or estrogen, and then they put a little bit of cholesterol in there to hold it together. I prefer the cholesterol pellets myself. It's not going to change your cholesterol profile in your patients, if you're wondering that. It's just there to hold the device, or sorry, hold the pellets in form. And then you insert the sterile pellets in subcutaneous fashion, and then they slowly are absorbed by the body or accessed by the body relative to the surface area of the pellets, right? So it's relative absorption based on the surface area of those pellets. Here are some other ones. I don't want to go too far into this. I want to be able to show you guys a video, but here's some of the pre-insertion labs you guys can look back over as you go through this. You want to check their estrogen, the testosterone, the progesterone. You want to check their FSH. You want to check their thyroid. We're not just pulling quick testosterones and putting them in patients, right? You need to look at the whole profile. You need to look at a CBC. You need to look at their FSH. You need to look at these. Maybe it's thyroid, maybe it's not hormones at all. Like, you have to do a full, thorough investigation. I also check A1Cs preemptively on all my patients. I use continuous glucose monitoring in some of my patients. So we do things outside maybe the normal insurance mandated ways that you can't do these labs because they're not indicated by a diagnosis of diabetes. I'm like, yeah, but I'd still like to get them before they get diabetes, right? So check these things. For most patients on the female side, it's somewhere between 14 to 16 weeks for reinsertions. It can be as long as 5 months. It can be as short as 3 months. For men, you're really trying to get to maintain the testosterone to a normal male testosterone, 8 to 1200. Most, if not all, are always over 600 post-treatment. And again, you want to check PSAs, right? We're not just checking testosterone. The testosterone is the least likely post-insertion lab that we're concerned about, right? We want to look at hemoglobin A1C. We want to look at their CBCs. We want to look at the PSAs. We want to make sure we're not doing a disservice to this patient, thinking like, oh, hormones just fix everything, and I don't have to worry about any of your other health markers. Like, it's important to know these things in your patients. So here is the device. So you have the tool, which has a trocar attached to it right down here. This is a pretty cool little device that they came up with, which I thought was rather ingenious. It's a precision scalpel. So the scalpel is deployed in a plunger type motion that is specifically measured to the same size as your trocar. So there's no taking an 11 blade and free cutting, right? It's pretty common. You're like, what's the difference between 4 millimeters and 8 millimeters from the naked eye? Pretty damn hard to know. But with the precision scalpel, your incision is only as big as you ever need it, right? Which is really, really cool. No more stitches ever. I don't even use any glue. You just use a few steri strips and they're off to the races. And it all comes in their device kit. So this is a male one because it's a dark gray, I can tell. 4.5 millimeter trocar. And then you have your scalpel down here. And then this little funnel, if you've ever done hormone pellet replacement, you would know this funnel is a simple, ingenious lifesaver. Again, these pellets for the estrogen are tiny, 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 and it's not uncommon to have dropped them on the floor, and you're like, oh crap, you're all sterile, and you're like, you got to go get another pellet. This little funnel makes things a lifesaver. Quick, easy. I don't run a volume practice, but you most definitely could off this if you had everyone set up and you had your patient set up and ready to go, anesthetized, numb, clean. Boom, you could rock in 2-3 minutes at most, be in and out. I do one, someone's in a rush without an assistant, 15 minutes from the minute they walk in the door and they're in their car. And I tend to be long-winded. So you can definitely speed it up if you want to. I prefer to sit and talk about patients. They've scheduled a concierge type visit anyway, so it's not a problem. Again, we talked about the precision scalpel, but it has this. Here's a good little picture. Like, it's this deployed. Where'd my mouse go? It's deployed here in this plunger fashion, and you can see, like, they're trying to show you as you pull that back, the blade is exposed. As the white gets approximated to the gray, a little self-retracting blade comes out. It has a safety lock on it, so your staff doesn't slice their fingers when they go to clean up after the procedure. So that's a pretty nice little feature too. Here's a picture down there of the traditional trocar. If you've used one, you recognize it. If you haven't, don't worry about it. they're becoming a thing of the past quickly and hopefully never to be seen again. I can't stand them from a patient perspective. They were just traumatizing to me. So the Pellecome device is such night and day difference from those conventional trocars. I always tell Pellecome, like, you don't have to tell me anything about selling your device. It just sells itself. Like, what was that old adage? I'm not only the president, I'm the, a customer or whatever, from the hair loss from decades gone by. But yeah, the old one was just so terrible. It was just awful. Extrusion rates were high. It was so painful afterwards. But a lot of docs didn't know it, right? Because who was doing the cleanup? It was me. It was the nurse. It was the person meeting them after hours to do stitches. It was me taking the phone calls and telling them how to stop the bleeding. It was the staff handling all that kind of stuff. And so a lot of times docs weren't even aware of what was going on. This is showing you how the trocars work. The good thing about the RE3 device is that it has this little safety angle right here, this plastic part that keeps a nice consistent angle, nice consistent depth every single time, so you don't get any there's no holding a device in one hand, pushing the pellets in with the other, and sometimes your hands moving up and down. You get pellets that overlap, lead to extrusions. You get none of that. It's all consistency with the Pellecome device. Again, this is the old device versus the new one. We'll leave that up there for just a half second, so if you want to screenshot it or pause the presentation afterwards, you can see it. But I want to get to the actual insertion. Let's see if this will play. Let's see if technology will cooperate with us.
Jeff, we can't hear it. Can you turn the volume up on your end on your computer?
Let me do that. And do I need to mute? No, I guess I shouldn't mute anything.
No, let's see.
Not very loud on my end.
Same.
Can you guys hear it, or do you want me to do some voiceover ad lib here?
Do some voiceover ad lib on there.
There you go. All right, I'll practice my radio voice here. See what I can do. All right, let me turn the volume down so there's not double talk. But what I'm going to show you is a male device in here. So that is the tool. I'm kind of going through what's in the kit here. So it comes with the scalpel. You've already seen this. It comes with the tool, and it comes with the needle for your insertion. So I was just talking about how it is specifically measured to the size of the device. There you go. Now showing how it locks. We may just skip right to the actual insertion video so you guys can see that. Where did my mouse go? There it is. And that's the mechanism. If it ever gets locked, you can unlock it. Showing you how to load the pellets through the device. It comes with a protective cap so that scalpel edge is not going to cut your hand. And then I show you how to insert it on a tool right here. So you line it up. Bad camera angle, I apologize. Should have come around from the other side. There it goes. There you go. And it's your pellets are inside there, and your device is loaded and ready to go. Locked on there is what I'm showing you. The male needles do come off, and I twist it like that. You pull it off, and then you can put on another loaded device if you needed to. So up to 3 pellets per track. Let's see if we can. Let's go to the actual insertion. I'll try to. Let's get to where we make the incision. That was good, right? So I'm going to lower that volume. I'm going to try to walk you guys through this. So I've anesthetized my patient. I've got my sterile drape. This is from their kit. They have a great procedure kit. It has all your sterile device tools in it, gauze, forceps. It has your extra needle. It has a syringe. It has all the stuff you need for a sterile kit. It's just plug and play. You don't need to think about, did I forget to order sterile anything? Boom, it's all in there. Nobody has to drop it on your tray for you. It's all ready to go. There you go. You make a small incision. Now this patient, I want you to watch. This patient is on over-the-counter blood thinner, so not aspirin. This is how much he bleeds. Nothing. Not anticoagulants. He's not on, significant, but he was taking aspirin. But it does affect the blood clotting. But again, no real blood at all. You expose the needle. You open the small incision, and you can kind of tell I've made 3 tracks there that I cleaned. You get your depth, so the needle is just buried a little bit. You're going to rotate, finish your depth till you see that plastic get right touching the skin. There it is. That plastic safety, which controls your depth so you don't go too deep. That's the purpose of that. You then drop your arm and you stay in that subcutaneous fat, and you're just gonna, and this person has significant scar tissue. So if you've ever used the old device, you would know you hit these pockets and they're tough to get through, right? But nice scalpeled edge, deploy the pellets, boom, you're done. Now this patient is a large patient, so males are 100% dependent on their body size. I think at the time of this video, he was 290, now down to 230, 228, if I remember correctly. So that's good. You'll hear this a lot from your patients. Just testosterone, I'm gonna put on weight, I don't wanna put on weight with hormones. If you exercise, you'll 100% lose weight. You'll put on muscle, but overall you'll have a net weight loss. So we've done 1 track or 3 pellets. We're gonna go back in and do another track of 3 pellets. Same consistent depth every time, touches the skin, drop your elbow, slide it in, right over the skin. And I think on this one I hit a little scar tissue, or maybe it was the last track. Deploy your pellets, perfect. Never have extrusions. I think I had, unfortunately, my first male extrusion in, what month are we in? So I had none last year for males, and we're in March. So that's what, 15 months? I had my first male extrusion, just got a call the other day. And I was like, my streak. But it's pretty damn rare. I'm doing these every day, all day, and I've had 1 now in 15 months. I was at 0, but unfortunately, we'll blame the patient maybe. It was a good time after the insertion, so I'm not sure exactly what happened. Last track, going in, nice consistent depth. I think this is the one you'll notice I had some resistance from some scar tissue, right? And with the old device, you would just really push and twist and drive through that. On this device, you don't do that. Nice, easy, slow, consistent, and then you can just see it pop right through that little pocket. And that's me just talking about that again. Boom. Deploy, good consistent depth, and we are good. If you're not talking, you're going at a normal speed, you're in and out of there pretty quick. A female is always only 1 track. So that was 3. You would only do 1/3 of that for a female. She would have her testosterone and estrogen in the same pellet. Their dosing is so much different than males that you only need 1 track for that. So it's even quicker for the females. Let's see if I show the incision closure. Yeah, so let's see what we got. I think I'm talking about scar formation and making sure that there's not any blood at all between the 2 incision sites. That keeps you from ever having to worry about scar tissue. I'm pretty much a stickler for that. Oh, did I just skip back on accident? So here's me putting the steri strips over. I lay them over, close each side of the incision, lay them nice and flat. And you'll either make fence posts, so I'll took 2 horizontal, some vertical, 1 on each side, or you do the standard asterisks. For males, I tend to go 2 straight across. They tend to be a little bit more, the incision's a hair bit bigger. They tend to be a little more active than my females, or less cautious, maybe be a better word. And then after this, you just do a little pressure dressing. Let me see if I can get my mouse to show up again. Let's see. I was just cleaning them off, getting that marker off him. So we look nice and pretty. Take a 2x2, you fold it in fourths. just like this. 1 tegaderm, pressure dressing. And there you go, little op site. Boom, that gives them waterproof. Hold 30 to 60 seconds. They can shower that night, stay out of hot tubs, bathtubs, lakes, oceans for 2 days. I don't want you soaking. Pulling up that waterproof bandage by any means and potentially exposing yourself to an infection. All right. So that's kind of the quick and dirty of it. I know we went through that kind of quick, but I wanted to make sure we got through anything and then we can answer questions. This talks about some of the Pellecome trainings that they do. I travel to doctors' offices. Doctors travel to my office. We do them online. They have practice management. They have dosing support. They have something really ingenious called the Pellet Doser that you get as a Pellecome trained doc, where it helps you guide your dosing in terms of how much estrogen should I do for a menopausal woman who's this age, has an FSH of this and an estrogen of this. I don't know how much to put in. I'm still learning this. You jot all that plus a lot more into what they call their Pellet Doser, and it gives you a great, it's Dr. Jacomb's baby, practicing OBGYN for many years. It is his algorithm-based diagnosis called the Pellet Doser that helps you hone in your dosing for your patients when you're unsure and you're still learning this. Questions, thoughts?
Well, Dr. Farah, thank you so much.
Might have gone pretty quick, but I was trying to squeeze that in my little time allotment. So if there's anything that we need to go over and we have time, I am more than happy to sit and talk with anybody. If anybody had questions.
No, it's great. It's a ton of information, but I think you did a great job of showcasing that. If any of our audience members today wanted to learn more, who should they contact? How should they get hold of?
Email, it would be email. You can call, but I would just shoot an email over to info@pellecome.com. That would be the best way. That would get distributed to me, Dr. Jacome, as well as the admin staff. So even if you're like, hey, I had some questions about the intricacies of hormones, I'm doing it, I don't know, whatever technical question you may or may not have had, or if you're just like, hey, I want to start doing this, I want to get trained, if you send it to that info@pellecome.com, that will get distributed to the right person.
That's awesome. I think one of the big parts right there at the top is a big deal, and certainly not mentioning the competition, but I think this is where in addition to the insertion, which you've covered, but the no contractual obligation and not taking fees for insertions. Listen, we talked about this at the onset, right? But you're looking for ways to improve revenues and maintain margins. This is why you're looking at alternatives. And when you're having to pay significant amounts to another third party for other things, it just cuts into that. So again, major differentiation right there, which I think is worthwhile mentioning as well. And that was one of the things that, as we looked at our partnership with Pellecome, that I was really drawn to. I'm like, wow, this is a game changer, right, in this space.
Sure.
So.
Yeah, it's unfortunate that some of the large players in this take a significant portion of your actual insertions. And if you know anything about business, which unfortunately in the medical community, us physicians and practitioners, we're maybe not the best business minds, but like it just punishes you for seeing more patients, right? There's no incentive to that. It's like economics 101. I love it. I can see as many as I want. If I see 100, or if I see one, you're not getting a cut of my business. You're not getting a bigger cut the more I grow, right? You're just paying for what you're actually using, which is the device. And that is a cost that's borne by the patient anyway in the service, and gladly, but you're not punished for the more patients that you see, which I think is a huge, huge, huge incentive. And the other competitors charge a significant rate, unfortunately.
Yeah. One of the questions that came in is someone that has not done this before, but first timers, how long does it take to feel comfortable, and the training process? You mentioned the online training, but certainly they've done things, but they're just wondering how long until you feel comfortable, inserting these in.
So I tell docs, I always recommend you do an in-person training, right? And am I a little biased because I do them? Sure, I guess. But when I learned to do this, I had been doing pellets already with the old device. I went and did it in person. I got home the next day, I started using it. So it is intended for Monday morning use. Now, if you have never done a procedure, I don't know, maybe you're a new nurse practitioner and you just doing telehealth, I don't know, you're doing psych health maybe, and you're not doing any procedure, sure, there could be a little bit of a learning curve, but that's the beauty of the device, is it makes it very, very smooth, easy, consistent. It takes away a lot of the error in that. So the trainings are intended to be Monday morning ready. By a few insertions, you have the nuance down perfectly. Women, 100% you're ready to go the next day. Easy peasy, tissue reasons why, one track. Males take a little bit of time to get perfected, but just like anything, you'll get better and better as you go along, but it is 100% intended to be Monday morning.
Perfect. That's awesome. Dr. Farah, thank you for your time, and thanks to our audience for being here today. Again, this has been recorded, and so it's going to be sent to you automatically. Look for this, it'll process tonight and whatnot, but it'll be sent to you via email tomorrow. It's about a 24-hour turnaround time. So look for that in your inbox tomorrow. But again, we appreciate your time today. You're always so knowledgeable. You do such a great job sharing your wisdom. So thank you so much. We look forward to seeing you again in the future, and thanks to everybody else. Take care and have a great rest of your day.